Good morning, guys. So today I'm going to talk about one of the very important lecture in pediatrics, that is congenital heart disease. So in this class, I will provide you the basic concept of congenital heart disease. We start right from the classification, okay? Then some discussion about the fetal circulation as well, because that is important to understand the whole concept of congenital heart disease. Then we'll talk about how a baby present with congenital heart disease, both cyanotic and acyanotic, and what are the important types. Then we'll mainly focus on VSD, ASD, PDA, and tetralogy of Fallot, because these are the important questions from the exam point of view. Let's start. Congenital heart disease, okay, regarding the incidence, they occur in about 0.5 to 0.8% of the live birth, but they are much more higher in premature infant and stillbirth. If we consider, the stillbirth, then the percentage would be much higher. Many of the babies, they die at the time of birth because of congenital heart disease. Congenital heart disease means the heart disease which is there from the time of birth. So probably some problem has happened during embryogenesis. Diagnosis is established within the first week of life in only 40 to 50% of the cases. In another 50% of the cases, the diagnosis is late. Probably the presentation is not that typical. Okay, that's why. Congenital heart disease is the leading cause of death in children with congenital malformation. Now, congenital malformation can be of two types, okay, minor and major. The major congenital malformation can be lethal for the life as well. Now, minor congenital abnormalities, we can take few examples there, like cleft lip and cleft palate. They are not lethal to the life. Okay, yes, they can cause some problem, but they do not cause death of the baby. Some other smaller type of anomaly, okay, like a pre-auricular sinus, pre-auricular tag, isn't it? Polyductally, these are the different types. Whereas the major congenital anomaly are like anencephaly, spina bifida, congenital heart disease, gastroschisis, omphalocele, okay, these are the major one. So out of that, congenital heart disease is the leading cause of death. Now, in the last class also, I discuss a little bit about this. Let's revise it today as well, because this is important for us. What about the fetal circulation and what are the changes occur after birth? Now see here. Here is the placenta. Okay, this is the area of placenta here. So umbilical arteries take the blood to the placenta. Okay, and from the placenta, after the exchange of the blood to the mother, umbilical vein takes the blood towards the baby. This is a baby circulation, fetal circulation. So umbilical vein takes the blood to the baby, and umbilical arteries take the blood to the placenta. Now look at the color of the blood here. These umbilical arteries are a little bit deoxygenated blood, so darker in color. This is, a bit red in color, isn't it? You can clearly see here. This umbilical vein, okay, bypasses the liver with the help of ductus venosus and drains into the inferior vena cava. Now this is a different stream of the blood. So this inferior vena cava is draining deoxygenated blood as well. Look at this blue one. Okay, it's the same blood vessel. So this is a two stream of the blood which is flowing there, and one stream is a oxygenated one, and another stream is deoxygenated one. So that oxygenated type of blood is directed towards the left atrium with foramen ovale. Okay, with the help of foramen ovale. And from there it will come to the left ventricle through the mitral valve. Left ventricle will lead to ascending aorta, arch of the aorta, and descending aorta, and again the same circulation follows. This one. Now, during the fetal life, lungs are non-functional. We all know that lungs are collapsed; they are non-functional, and the pressure inside the pulmonary circulation is way too high than the systemic circulation. Now, blood still comes to the right ventricle from right atrium. This is right atrium here. Here is the right ventricle. This is the pulmonary artery. But because lungs are non-functional and pressure is way too high, okay, this blood which is there in the pulmonary artery is diverted towards the aorta through ductus arteriosus. Ductus arteriosus. This is a very important structure in the fetal life. So we have notice three important structure in fetal life. One is ductus venosus, another is oval foramen or foramen ovale, and third is ductus arteriosus. Now, what will happen to this structure after birth? See here, ductus arteriosus closed and it is replaced by ligamentum arteriosum. We can clearly see there. If it still persists after birth, we call it patent, okay, ductus arteriosus, PDA, and that is an important type of congenital heart disease. This disappear. See this? Ductus venosus is no more, okay, and then the foramen ovale is also closed. So these are some of the important questions from the exam point of view. Now, having discussed that important part, let's classify the congenital heart disease. Now, congenital heart disease are roughly classified into two types: acyanotic and cyanotic type. Acyanotic type means there is no cyanosis at the time of presentation, but later on cyanosis may develop there. Okay, later on cyanosis may develop there. That is known as Eisenmenger syndrome. Whereas in case of cyanotic congenital heart disease, the baby presents quite early with cyanosis. Now, acyanotic type are again of different, we have divided them into different types. Left to right shunt is the most important one. Another is obstructive type of acyanotic heart diseases, and third are regurgitant type. Now, left to right shunt are ASD, VSD, endocardial cushion defect, and PDA. Every student know the full form here. ASD, atrial septal defect. VSD, ventricular septal defect. Endocardial cushion defect or ECD. Actually, they are a part or type of ASD itself. ASD are of different type. We'll talk about that later. Mainly sinus venosus, ostium secundum, and ostium primum. Ostium secundum is the most common one, but ostium primum is the most complicated one. And ostium primum is also known as ECD or endocardial cushion defect. Okay, this is PDA, patent ductus arteriosus. Now, see here, obstructive one are PS, pulmonary stenosis, aortic stenosis, COA, coarctation of the aorta, and mitral stenosis. If PS is very tight, pulmonary stenosis is very tight, it can lead to cyanotic heart disease. PS is an important part of tetralogy of Fallot. Okay, we'll talk that later. Regurgitant lesions are pulmonary regurgitation or insufficiency, mitral regurgitation or mitral insufficiency, mitral valve prolapse, tricuspid regurgitation, and aortic regurgitation. Any of them may be there from the time of birth, but this left to right shunt are much more common than other. Now, what about the cyanotic type? See here, the cyanotic, congenital heart disease. Very important question in the Viva exam for the students. Tetralogy of Fallot, TOF. Tetralogy of Fallot, okay, is the most common cyanotic congenital heart disease. Then tricuspid atracia, okay, TGA, transposition of great arteries, TGA, transposition of great arteries. Let me go through the names first, then I'll explain. TAPBR, total anomalous pulmonary venous return, and then Truncus Arteriosus. These are 5 T's which you can remember like this. Very easy. Just remember 5 T's: TOF, tricuspid atracia, TGA, TAPBR, and Truncus Arteriosus. Now, apart from them, some more are there, like pulmonary atracia. Okay, DORV and PS. DORV without PS. This is double outlet right ventricle and pulmonary stenosis, Epstein anomaly, and single ventricle. Now let's elaborate a little bit on them, because the student must understand what's the meaning of these important terms. Now, can anyone tell me what are the four components of tetralogy of Fallot?
Sir, pulmonary stenosis, ventricular septal defect, overriding of aorta,
Pulmonary
right ventricular
stenosis,
hypertrophy, and arterial septal
right,
defect.
Yes,
Right,
yes.
right ventricular hypertrophy,
Good.
pulmonary stenosis.
Okay. Now I already got the answer.
VSD.
I already got the answer. Excellent. Now listen here. We'll talk about that is a major part of this class. Tetra means there are four components. Tetralogy of Fallot, four component. The most important component is pulmonary stenosis. Pulmonary stenosis, PS. Okay, or right ventricle outflow obstruction. It is also known like that. The second one is VSD. Okay, VSD. The third one is overriding of aorta, and the fourth one is right ventricular hypertrophy. So these are the four one. PS. After PS, it is easy for you to remember maybe right ventricular hypertrophy, because PS usually gives rise to right ventricular hypertrophy. Then ventricular septal defect and overriding of the aorta. In any order, you can answer this. It doesn't matter. Tricuspid atresia. Atresia means the tricuspid valve is not formed. Tricuspid valve is not formed. Now, this is a big or massive congenital anomaly. If tricuspid valve is not formed, then there is no communication between right atrium and right ventricle. Okay, right ventricle is very, very hypoplastic during that time, whereas right atrium is a bit big in size. There has to be some other, connection, otherwise the baby cannot survive. TGA, transposition of great arteries. What do you mean by that?
Right, pulmonary veins from right ventricle and
May I explain, sir?
pulmonary artery from left ventricle.
Sir, may I
Okay.
explain, sir?
Yeah,
Sir,
sure.
may I?
Sure.
Basically,
Aorta arises from right ventricle,
Uh-huh.
sir,
and
may I explain, sir?
there is pulmonary stenosis and ventricular septal defect, as well as patent ductus arteriosus.
Yes, Uzair. Yes, go on. Yeah, I have heard him. Yeah, very good. Okay, good.
Sir, basically, sir, the two main arteries they are taking blood away from the heart, the pulmonary artery and the aorta. Like, sir, they have changed their position, and sir, now what will happen, sir? The aorta will directly put the oxygenated blood back into the lung, and the pulmonary artery will put the deoxygenated blood to a systemic circulation. So, sir, we will have central cyanosis directly.
Okay. Now he is right. So just all of the students, this is an important question. Very, very easy one. See, these are the two big blood vessels which are coming from the heart. They are pulmonary artery and the aorta. Just focus on that. So usually in a normal babies or normal cases, aorta originates from left ventricle, pulmonary artery originates from right ventricle. Okay, these are the arteries, not the vein. Aorta from left ventricle, pulmonary artery from the right. These are the normal cases. Now look at the term transposition, means they have changed their origin. In this case, aorta is originated from the right ventricle and pulmonary artery is originated from the left ventricle. Now this is totally wrong type of circulation, because right ventricle has deoxygenated blood, and that deoxygenated blood is continuously circulating throughout the body through aorta now, whereas our left ventricle has oxygenated blood which is constantly taken to the lung. So the baby definitely will be cyanosed, and this baby also or should have some type of connections, otherwise the baby cannot survive. Okay, so usually they have PDA for the survival purpose. TAPBR is total anomalous pulmonary venous return. Very easy concept. In this case, the pulmonary vein drains the blood into the right atrium. Normally, pulmonary vein drains the blood into the left atrium, but this is an anomalous type of circulation, so it is taking blood directly into the right atrium. So all the blood is mixing there, both deoxygenated as well as oxygenated. So this is also a type of cyanotic heart disease. Truncus arteriosus. Now this truncus arteriosus means before ascending aorta and pulmonary trunks are developed, they used to be a single trunk. Then a septum would develop there, and they will divide into two big blood vessels, and they are separated. This is the normal embryology. But what happened? That type of normal development, doesn't occur. So they still remain as a single trunk. So all the blood is mixing there. This is known as Truncus arteriosus. So these are a massive type of congenital anomaly. Pulmonary atracia. Now in this case, the pulmonary valve is not formed. Atracia means not developed. DORV, double outlet right ventricle. Both aorta and pulmonary artery is originating from the right ventricle. That's why we call it double outlet. Okay, so left ventricle doesn't have a big role here. This is with PS, this is without PS. PS is pulmonary stenosis. Now, Epstein anomaly is a special type of cyanotic congenital heart disease, okay, where there is atrialization of right ventricle. This is known as atrialization of right ventricle. Means right atrium is a huge one and right ventricle is a very small chamber. This is Epstein anomaly, and they should have some other connections also. Single ventricle, there is no interventricular septum. Both ventricles are a single chamber, so everything is get mixing there. So these are different type of cyanotic heart disease. Okay, now let's move on. Now, after knowing this classification, how to take the history, how these babies present. We have to take the detailed antenatal and gestational history from the mother. Was anything wrong during pregnancy or not? Very, very important question, because there are certain illnesses which can lead to congenital heart disease during pregnancy. If the mother was taking some medicine, probably those medicines were causing some defect in the embryogenesis and leading to congenital heart disease. So good history should be taken. We'll provide different example later on. Postnatal and past history also should be taken. How the baby react after birth. Was there cyanosis right there at the time of birth or not? Or how many days after birth the baby manifested? Family history is also very important here. Maybe multiple members in the same family have developed heart disease. Now, these are the maternal conditions which we must ask in history taking, and these maternal conditions are associated with cardiac lesion. Now see here. If mother suffered from fever with rash during pregnancy, who knows, that may be a case of rubella. Rubella is also known as German measles. It is not serious infection at all in the adults, but especially if that pregnant lady develops rubella during first trimester, then the developing baby can develop massive or lethal congenital anomaly, and that is known as congenital rubella syndrome. Some of the important cardiac lesions in this case are PDA and peripheral pulmonary stenosis, especially PDA. This is important MCQ question in your exam. Please remember this. Patent Ductus Arteriosus, manifestation of congenital rubella, and this is peripheral pulmonary stenosis. This is not a valve stenosis, this is some branches of the pulmonary artery which are stenosed. Now another one is diabetes mellitus or diabetes. So infant with diabetes mellitus, which are born to gestational diabetes or chronic diabetes, can have this type of cardiac lesion like cardiomyopathy, TGA, VSD, and PDA. Any types of heart disease can develop in infant with diabetes mother. Maternal phenylketonuria, PKU, phenylketonuria, okay, can have VSD, ASD, PDA, and coarctation of the aorta, COA. And maternal SLE can have heart block in the baby. This is a third degree or complete heart block. Third degree or complete heart block. And in complete heart block, the heart rate is very, very low. And probably for the survival, we need to put pacemaker there. So these are some of the important examples. Now, if mother was taking some drugs during pregnancy, like maternal drug ingestion, then these are the effect of those ingested drug on the baby. Like alcohol, if that lady was drinking during pregnancy, even a bit of drinking, it's not necessary that she should drink every day. So that alcohol is quite damaging for the developing baby. This is known as fetal alcohol syndrome. Fetal alcohol syndrome, it may have this type of manifestation like VSD, ASD, PDA, and tetralogy of Fallot. If mother was taking retinoic acid, what is retinoic acid?
Vitamin A.
Very good.
Vitamin A derivatives, sir.
Exactly. You can say vitamin A derivatives, or even if you say vitamin A, that is acceptable answer. So don't, we don't prescribe vitamin A derivatives or vitamin A directly to the mother during pregnancy. It can lead to conotruncal anomaly. One of the perfect example of conotruncal anomaly is Truncus Arteriosus. Truncus Arteriosus. Phenytoin is a type of anti-epileptic drug, can have this type of congenital heart disease, pulmonary stenosis, aortic stenosis, and coarctation of the aorta. Sodium valproate, another type of anti-epileptic drug, can have coarctation of the aorta, hypoplastic left heart syndrome, and aortic stenosis. And warfarin, a type of anticoagulant drug, can lead to VSD. Okay, so rather than what type of congenital heart disease they cause, try to remember the name of those medicine. Okay? And if you say some important type of congenital heart disease are caused by them, that is acceptable answer. But these are the important questions from the exam point of view. Now, what is the relation of birth weight, okay, and a congenital heart disease? Now, see here. Rubella is a type of intrauterine infection. Okay, it's a part of torch group of infection. Torch group. Okay, now I'm sure every student know this. Torch group of infection. That TORCHS. Now we all know the full form of this. T stands for what?
Sir, toxoplasmosis.
Exactly, toxoplasmosis. Okay, or sometimes this O is also included there. Toxoplasmosis. R stands for rubella,
Rubella.
isn't it? Rubella. That's what we are talking right now. Rubella. C stands for
Cytomegalovirus.
Cytomegalovirus.
very good. Cytomegalovirus. H stands for
Herpes simplex.
Simplex virus, sir.
very good.
Herpes
Herpes
simplex.
simplex virus. Excellent. And S stands for syphilis.
Syphilis.
Very good. So all of you should know this. Okay, this is one of the pet questions of the examiner. Toxoplasmosis, rubella, cytomegalovirus, herpes simplex virus, and syphilis. These are called intrauterine infection. Now, okay, what I'm trying to explain here, any of these can lead to decreased growth of the baby, which is known as IUGR. So they lead to IUGR, and IUGR, babies look quite small at the time of birth. So birth weight is smaller. And according to the definition, okay, IUGR is also commonly known as SGA, is small for gestational age. Okay, so if the birth weight is less than 10th percentile at the time of birth, this is known as small for gestational age. Between 10th to 90th percentile, this is called appropriate for gestational age. and more than 90th percentile is known as large for gestational age. I will talk about that in our neonatology classes. Okay, we'll extensively discuss this type of things there. Now, another point, the birth weight is increased in infant of diabetic mother. You already know that. Diabetic, okay, or diabetes mellitus can be of two types during pregnancy. One is called gestational diabetes. Okay, in obstetrics you have already studied that, and another is called chronic diabetes. If mother is diabetic during this pregnancy, then there is a high chance of increased size of the baby. Okay, the baby probably is more than 4 kg, or baby will be large for gestational age. Whereas if the baby, if the mother is having chronic diabetes, then because of some complication, the baby may be born as IUGR baby. Now, let's take history in the postnatal life. If there is a decrease, weight gain, okay, decreased weight gain, development, and feeding, all of these are decreased rate of development and decreased feeding. Probably these are the causes: cyanotic congenital heart disease, congestive cardiac failure, and syndromic baby, like Down syndrome, for example. Okay, Down syndrome is very commonly associated with endocardial cushion defect, a type of a cyanotic heart disease. If there is a persistent cyanosis in the baby, remember, a baby cannot gain weight. Okay, and congestive cardiac failure, if it is a chronic type, then also similar type of things can happen. Cyanosis, cyanotic spell, and squatting are commonly seen in cyanotic heart disease, especially in tetralogy of Fallot and other types of cyanotic heart disease. Now, cyanosis, okay, let's define it. What is cyanosis?
So there is a higher level of the deoxygenated leading to the grayish discoloration of skin is known as cyanosis.
Okay, good. I agree with your definition. Any other student, please? Anyone?
Deoxygenated hemoglobin is more than 5 milligram per deciliter.
Okay. Now, cyanosis is the bluish discoloration of skin and mucous membrane when the reduced or deoxygenated hemoglobin is more than 5 gram per deciliter. Okay, this is gram, not milligram. Please remember that. Gram per deciliter. Hemoglobin is always measured as gram per deciliter. So let me repeat again. Bluish discoloration of skin and mucous membrane when deoxygenated or reduced hemoglobin is more than 5 gram per deciliter. Now, there are some exception here. Sometimes what happens, the total hemoglobin itself is less than 5 gram. Then how can the baby manifest as cyanosis? That is a very good question to ask, because there are certain hemolytic anemias, like thalassemia is one of them, where hemoglobin is extremely low, sometimes even 2 to 3 gram per deciliter. That can happen. So in that case, the child will not be cyanosed. The complete cyanosis are very blue. The child just look dusky, slight blue tinge may be there, because the hemoglobin content is not that much. So cyanosis is not properly seen in them. But if hemoglobin is of good amount in the body, and if there is a deoxygenated amount more than 5 gram per deciliter, cyanosis can be easily detectable. Now, cyanotic spell means on and off cyanosis. In between, the baby is not that cyanotic, or maybe a little bit cyanotic only, but during cyanotic spell, he is totally blue. This occurs when pulmonary stenosis becomes more. And there are certain situations where pulmonary stenosis become more, like if the baby is agitated or afraid. Okay, that is important condition. Squatting is a position. Okay, you all know squatting position. Squatting position means you act like a sitting on the ground, but not completely. Your buttocks are still folded up. Okay, knees are folded, and you have not completely sit on the ground, but you are about to do that. That position is called squatting. Squatting position is commonly attained by the baby who is having congenital cyanotic heart disease, especially tetralogy of Fallot. And there is a reason for that. If the baby attains that position, then afterload is increased. Afterload is increased. And after increasing the afterload, the shunting which is happening between the left ventricle and the right ventricle is less, and the baby will be less cyanosed. Or if the baby was having difficulty to breathe or dyspnea, it will become less. In tetralogy of Fallot class, I will talk about that once again. Squatting. This is just a history taking now. So remember, we should ask that history. Ask about tachypnea, okay, dyspnea, and puffy eyelid. Tachypnea, dyspnea, and puffy eyelid. Tachypnea is faster breathing. Dyspnea is difficulty to breathe, and puffy eyelid is a feature of edema. Okay. Now let's move on. Now, what are the other important history taking we need to do in case of postnatal life? Again, frequency of respiratory infection has to be asked. How many times the baby suffered from pneumonia or lower respiratory tract infection? How many times the baby was admitted to hospital? Okay, very, very important question. Now, let me explain this. What is the connection of repeated respiratory infection or pneumonia and congenital heart disease? What is the connection? Anyone? Anybody?
Sir, in the
Cyanosis, sir.
congenital heart disease, sir, like VSD is ASD, there is left to right shunt, so more blood will goes to the lung, and
Good.
And more if organism is present in the blood, so it will cause the
Good.
respiratory infection.
Very good. Yes, yes. Some other guys. Yes, very good answer he has given. Excellent. Anybody else? Now listen. Okay, all of you. He is almost there. Absolutely correct answer he has given. So see here. Left to right shunt means the chamber which are present on the left. These are left atrium and left ventricle. The blood is moving from left to the right side through the defect like ASD and VSD. And if I consider PDA also in that group, then from aorta, the blood is flowing to the pulmonary artery. Okay, so all of these are left to right shunt. Now what will happen? Where that blood will go now? Ultimately, the blood will reaches the lung. So lung is flooded with the blood. You think like that. Lung is wet all the time. Okay, and if lung is wet all the time, then there is a high chance of secondary infection. I'm making it very simple. There is high chance. That's why if a baby is having recurrent pneumonia, recurrent more than one time and quite quickly also, I always need to think as a doctor, just don't only treat, treating is very easy. Giving antibiotic is easier, giving oxygen is easier. But I need to ask myself why this baby is having repeated pneumonia. What may be the cause? One of the most common cause is left to right shunt type of congenital heart disease. So I must send the baby for echocardiography, chest X-ray, ECG, and those type of investigation, and the disease can be easily diagnosed. Asks about exercise intolerance. Now this is a feature of dyspnea. Okay, exercise intolerance is seen in dyspnea. This may be a feature of heart failure. Chest pain. Okay, it's seen in mitral valve prolapse, and again in some of the pulmonary arterial hypertension cases. And palpitation is a common feature of mitral valve prolapse, or even in different type of other heart diseases. So these are the questions we should ask. Now, neurological symptoms should be asked, like neurological deficit or stroke, or if the baby is very small, we should try to get the data, okay, or report from the hospital. Probably because of this condition, the baby was admitted there, or during the admission, the baby has developed these things, isn't it? So this is the way of taking a history here. Now, the neurological symptoms are stroke, headache, and syncope. Now, why stroke is so common in congenital heart diseases? Anybody? Why? Who can answer that?
Sir, stroke, that's why, sir, there is a direct relation between right and left. If there is any thrombosis or any embolism formation, sir, there is no passes through the lungs. That's why, sir, it leads to stroke.
Okay, okay, good. I'll consider your answer. Yes. Another answer is low perfusion. Then
Because
Sir,
our brain need oxygen in every single second. So here oxygen is less supplied, so it can cause low oxygen.
good. That is also
sir,
yes.
When
in
many
congenital heart disease,
Yes, one by one. Yeah.
sir, in this disease, sir, hypoxia occur, and hypoxia will lead to polycythemia and chances of thrombosis. In this case, it will cause stroke chances.
Excellent. Now see there. All the answers have come from your side. Now let me regroup those answers only. Okay. Very good. So you are thinking in a very good direction here. Now, what is happening? We need to understand. One, in cyanotic heart disease, there is cyanosis most of the time. Cyanosis means it's a hypoxic situation. Hypoxia will lead to increased erythropoietin release. Increased erythropoietin leads to increased RBC formation. This is known as polycythemia. Polycythemia is a thrombotic condition. It can easily lead to thrombosis in the cerebral circulation and lead to stroke. Another one, decrease cardiac output, okay, or decrease blood flow towards the brain, definite reason for stroke formation or stroke, definite cause. So there are multiple reasons for that, but the most important one is associated with polycythemia, which is commonly seen in cyanotic heart disease. And the third one is paradoxical embolism, okay, which you have already mentioned. Another is headache, and third is syncope. Now, headache is quite common because of all these problems, whatever is happening in the brain, headache can be there. And syncope. Syncope means transient loss of consciousness because of decreased blood flow to the brain, which is very common in heart conditions. Now, what about the family history? What is the importance of taking family history in case of congenital heart disease? Now, see there. If one parent or sibling is affected, the incidence of having congenital heart disease is 2 to 6%. Whereas if two first degree relatives are affected, then the incidence is 20 to 30%. So it shows how important is this history. Okay, it may run in the family, and this gives us a very important clue. Asks about the history of sudden deaths in family. Any heart disease can lead to sudden death in the family. Any. It's not only ischemic heart disease, any type of heart disease can do that. And take the history of hypertension and diabetes also. Okay, let's move on. Now, after this, important, history taking, let's do the general physical examination of that baby. Now, look at this, baby here. This baby looks dusky or blue. Okay? Not completely blue, but dusky. Look at the lips here. Okay, and this baby looks a bit plethoric also. This is known as plethora, and plethoric baby looks a bit dusky because plethora means polycythemia. Polycythemia has high, amount of RBC, and if there is a cyanosis occurring, that cyanosis can easily be seen. Okay, this baby is attached with so many different leads. Okay, oxygen is given. And this baby looks very sick, a bit of bloated as well. First, thing is taking vital sign. So respiratory rate, heart rate, blood pressure, temperature, and pulse oximetry. Okay, let's add pulse oximetry also here. Okay, this is the fifth one for us, pulse oximetry. And this is the condition where pulse oximetry is really important, because uh, the baby may present with heart failure, okay, with decreased perfusion of the periphery, and pulse oximetry can detect that, the extent of hypoxia. Regarding the pulses in arms and leg, one of the condition every student know is coarctation of the aorta. Okay, there is radiofemoral delay in coarctation of the aorta. Radiofemoral delay. This is a very important feature. So when we check the pulse, check for the volume of the pulse, check for the character of the pulse, and check for radiofemoral delay. Now, I'm sure you have already studied this in internal medicine side when we talk about cardiovascular system. If you haven't done that, then during the practical discussions of those systems, how to examine them, we'll definitely talk about it. Now, blood pressure is routinely taken, especially in sick babies. Again, I want to highlight the example of coarctation of the aorta. Blood pressure is higher in upper limbs in coarctation of aorta than in the lower limbs. Now, see here, all of you, please look at this picture. This is called coarctation of the aorta. Now, see here, this acute narrowing of the arch of the aorta, coarctation of the aorta, and this coarctation is occurring after subclavian artery is originated. Okay, after subclavian artery is originated. That's why the head and neck areas are not affected by this. Only the lower part of the body is affected by this acute narrowing. That's why there is radiofemoral delay. The femoral pulse comes later than the radial pulse, and the pressure is also low in the lower extremity than the upper one. This is very, very important understanding. Now, what happens to the heart because of this acute narrowing? Okay, now see here, this is just like a stenotic lesion. So it will lead to increased pressure development in the left ventricle. Okay, increased pressure development in left ventricle, because there is a lot of resistance felt by the left ventricle to pump the blood. Over a period of time, left ventricle will become thicker in size. This is known as hypertrophy, and this hypertrophy is a concentric type of hypertrophy. Concentric, it thickens towards the lumen of the left ventricle. Okay, so now you all know what will happen. The overall size of the left ventricle is suffering. It is becoming decreased. There is decreased amount of collection of the blood here. Okay, so this can lead to heart failure later on. Okay, later on. Now, another part of general physical examination is anthropometry. Anthropometry means we take different type of measurement of the baby or the child, like weight, height, OFC, occipitofrontal circumference, also known as head circumference, occipitofrontal circumference, and arm span. These are the important anthropometric measurement. Now, in which case arm span is routinely measured? Anybody? In which case?
Marfan syndrome.
Excellent.
Yes, sir, Marfan syndrome.
Excellent answer. Marfan syndrome. Very good. In Marfan syndrome, arm span is more than the height. Okay. Very nice. Occipitofrontal circumference or head circumference is routinely measured if the baby is less than 2 years of age to diagnose whether the head size is small or the big. It may be connected or associated with different congenital anomaly. And height and weight are routinely taken just to make sure what is the effect of this long-term heart disease on the weight gain and height gain of the child. Usually there is decreased weight and decreased height in case of heart diseases. If there is congestive cardiac failure, the weight may look a little bit more, but that is purely due to edema. Now, let's comment something about the general appearance of the child. We should look at the activity of the baby. The baby is active or not, or very irritable. Sometimes the baby is very irritable because of hypoxia. Okay, and if the baby is fine, means all the symptoms are controlled, the disease is under control state, then the baby may be quiet. So activity is also important one. Nutrition, just now commented, take height, take weight, and look for the overall nutritional status of the child. Are there any signs of vitamin and mineral deficiency or not? What about the features of malnutrition? Okay, just examine that if there are any. And look for dysmorphism. Now, dysmorphism or a dysmorphic feature means it's a difference of body structure. It's a difference of body structure. Now, what does that mean? Now, what happens sometimes when we see a baby, we feel that baby doesn't look normal. Okay, we keep on looking at that baby. This baby doesn't look normal. Something is there on the face. So that type of feature is known as dysmorphism. Okay, so a typical example is again Down syndrome baby. There is some anomaly on the face, like slanting of the eye, palpebral. There is a small tissue, a piece of tissue present on the medial canthus of the eye. Okay, palpebral fissure. All those things may be there in the face. So this is known as dysmorphism. This may be associated with heart disease. Now, see here, there are different examples, which are provided here, and many of the students already know this. Down syndrome, which is known as trisomy 21, is associated with endocardial cushion defect, VSD, and ASD. Trisomy 18 and 13. Trisomy 18 is known as which syndrome?
Sir, Edwards syndrome.
Edward.
And 13? 13?
Patau syndrome.
Patau.
Sir.
Very good. Patau syndrome. So Edwards syndrome and Patau syndrome, these are trisomy 18 and 13, similar conditions like Down syndrome. So they are associated with these type of congenital heart defect, PSD, ASD, PDA, and coarctation of the aorta. Turner syndrome, this is seen in girls, 45X only, one X chromosome is deleted. It is strongly associated with bicuspid aortic valve and coarctation of the aorta. Very, very important MCQ question in the exam. Okay, so let me, see here, this, you should never forget this, endocardial cushion defect in a case of Down syndrome, absolutely important point. And another one, in case of Turner syndrome, there is coarctation of the aorta, okay, as well as bicuspid aortic valve. So try to remember this. In Fragile X syndrome, okay, these are usually boys. They usually have mitral valve prolapse and aortic root dilatation. Aortic root dilatation. Okay, let's move on. Now, what are the other parts of general examination? We are moving to the important one now, that is color. Okay, color. The baby may be cyanosed, the baby may be jaundiced, and the baby may be pale. These are the different problem in the color. Now, we already defined cyanosis. This is bluish discoloration of skin and mucous membrane when the reduced hemoglobin is more than 5 grams per deciliter. Now, there is another term called differential cyanosis. Now, differential cyanosis occurs when there is PDA after reversal of the shunt. Now, let me explain this for you. PDA, where is the direction of blood flow in PDA? PDA, from where blood starts and where it ends in PDA? Yes,
Sir, in the fetus, sir, from the pulmonary trunk to the aorta, and
Yes, sir.
after
Sir, it is due to the pressure difference. Sir,
after daily.
sir, first it is from pulmonary artery to aorta, but sir, after the pressure difference, it reverses and goes from aorta to the pulmonary artery.
Excellent. All of you are answering correctly. I got your meaning already. Okay, very good. So in the fetal life, okay, in the fetal life, that is known as ductus arteriosus, the direction of flow is from pulmonary artery to the aorta. But after the birth, if it persists, then only we call it PDA. And in that, the direction of blood flow is from aorta to the pulmonary artery. From aorta to the pulmonary artery. Now, when there is development of pulmonary arterial hypertension, please listen carefully. When there is development of pulmonary arterial hypertension, then again there is reversal of the blood flow. Again it starts to flow from pulmonary artery to the aorta. Now a bit of deoxygenated blood is going towards the leg. Going towards the leg. Now in this condition, the foot or the lower limbs are relatively sinus than the upper one. This is because of the reversal of shunt in PDA after the development of pulmonary arterial hypertension, and this is known as differential cyanosis. This is known as differential cyanosis because pulmonary artery is carrying deoxygenated blood. Now that deoxygenated blood is going towards the lower limbs. Upper limbs are not properly or typically affected here. It's all about where is this ductus arteriosus located. Remember, the ductus arteriosus is again present after the subclavian artery is originated. Okay, a bit like coarctation of the aorta explanation. So the blood will flow distally, the lower limbs will be sinused. Differential cyanosis. Jaundice. Why jaundice occurs in heart failure? What is the cause of jaundice?
Sir, may I explain, sir?
Yeah, sure. Sure.
So we have got two mechanisms in here. Sir, the first one, like for example, if we have a left to right shunting, so sir, there is a sort of a backflow, sir, which will cause the hepatic venous congestion, and so this hepatic venous congestion can lead to the jaundice. The second mechanism is that, sir, if we have if we have a delay like say like the cardiac output is less, so it can also lead to an ischemia to that like hepatic ischemia, sir, which can lead to the ischemic hepatitis. But sir, like to know about the cause of this, sir, whether it's the first mechanism or the second mechanism, sir, we can do an aminotransferase test. Sir, the aminotransferase will be higher in the ischemic hepatitis, but sir, in the venous congestion, hepatic venous congestion, it will not be high, sir. So sir, these are the two mechanisms, I think, for jaundice.
Very good, excellent. Okay, excellent. I'm sure so many other students also know this. Let me highlight this again. He has given a very good explanation here. Number one, in case of congestive heart failure, especially in right-sided heart failure, there is congestion of the liver. Okay, this is known as congestive hepatomegaly, and that congestive hepatomegaly or congestion of the liver can lead to slight jaundice. It is never that serious type of jaundice because this is mainly congestive type of damage there. Now, second one, when there is very, very low cardiac output, especially in cardiogenic type of shock, probably, then the liver will suffer from ischemia. Absolutely correct. And that ischemic damage of the liver is much more serious than the congestive damage of the liver. So all the signs and symptoms, all the enzyme elevation are much more higher there. Okay, these are the causes of jaundice. Third one is pallor. Now pallor, this heart disease, remember, if it is a chronic type, the baby will become malnourished, and that malnutrition can lead to pallor commonly. Okay, but if it is cyanotic type of heart disease, then the baby doesn't suffer from pallor. Rather than that, the baby suffers from plethora or polycythemia. It depends which type of heart disease we are talking about.
Excuse me, sir.
Yes, please.
Sir, in jaundice, sir, in cyanotic heart disease, sir, we already know there is hypoxic condition and lead to the polycythemia. And sir, we can also add this point. In polycythemia, there is hepatic artery thrombosis or hepatic vein thrombosis lead to hepatic failure or jaundice.
Exactly. You can add. Very good thinking. Another one. Yes, why not? Because in case of polycythemia, remember, there is a high chance of hepatic vein thrombosis or Budd-Chiari syndrome. That Budd-Chiari syndrome also gives rise to hepatic vein congestion acutely. So the similar mechanism, it is again because of acute hepatic congestion. Okay, the mechanism is similar, but the explanation is a little bit different. Of course, medicine is all about that, guys. Think in a different direction, and if you give explanation, if you satisfy your senior or your professor or teacher with your explanation, then that is medicine. So you can always think, can this be the cause? Can this be the association? Okay, this is the proper way. Very good. Let's move on. Now, let's talk about what are the differences between central cyanosis and acrocyanosis. Now, acro or acral means peripheral part of our limbs. You see this, these are the acral parts. Okay, hands and feet are the acral parts, and central part means it is the lips. Okay, it's a face, it's an oral cavity. That is the part we examine. So if only hands and feet are cyanos, we call it acrocyanosis. And if the central part of the body means lips, oral cavity, okay, are cyanos, we call it central cyanosis. Central cyanosis means whole body is cyanos, frankly speaking. So acrocyanosis is a part of central cyanosis. But okay, sometimes only acrocyanosis is there without central cyanosis. So see here, when a baby is delivered, we talked about that in Apgar score also. When a baby is delivered in the delivery room or anywhere, for few hours, the hands and feet of the babies are quite cold and they are cyanotic. This is typical acrocyanosis, what is happening. And this occurs because of vasoconstriction as a result of low temperature, because the baby was having very good soothing temperature before the birth, but after the birth, sudden drop in environmental temperature can lead to acrocyanosis. And it may last up to 7 to 2 hours sometimes after the birth. Now, one question for you. In case of heart failure, if you see only the acrocyanosis, what may be the cause now in heart failure? Only the acrocyanosis. What is the cause?
Mitral stenosis.
Mitral stenosis.
Mitral stenosis.
Okay, one is decreased blood flow itself, mitral stenosis, and another one is explanation. You can easily give this explanation in any type of heart failure, any type. There is usually sympathetic system activation. Sympathetic system activation can lead to vasoconstriction, and that vasoconstriction is responsible for acrocyanosis. Okay, so it's quite common in case of heart failure. But if heart failure is associated with pulmonary edema or serious type of congestion of the lung, then even central cyanosis can occur there. Now, there is one important test which we do just to make sure what is the cause of this cyanosis here. And this test is known as Hyperoxia test. Cyanosis can occur in pulmonary disorder as well as in cardiac disorder. Now, the common causes of cyanosis in cardiac disorder are cyanotic heart disease. That's what we are talking now. Whereas in severe type of lung diseases like severe pneumonia, okay, severe type of bronchial asthma, pulmonary edema, pneumothorax, cyanosis can occur there also. So how to differentiate? The cyanosis is caused by lung disease or cyanosis is caused by heart disease, we do hyperoxia test. Now, how this test is done? Please pay attention here. It is performed by measuring the arterial blood gas or ABG of the patient while he or she breathes room air, then remeasuring the arterial blood gas after the patient has breathed 100% oxygen for 10 minutes. What do we do first? We do the baseline ABG when there is no oxygen given, baseline that is called. We do that. Then we give 100% oxygen for 10 minutes for the patient. Then after that we do ABG again. Then we just compare what are the changes. Now look at the interpretation here. If the partial pressure of oxygen rises more than 150 millimeter of mercury, then this is because of the lung condition. But if the partial pressure of oxygen remains less than 100 millimeter of mercury, even after giving this 100% oxygen for 10 minutes, then it is the right to left shunt or cyanotic congenital heart disease, which is causing cyanosis here. So let me repeat again. So actually what we are doing, this ABG means, there are different components of ABG. One is pH, another is PaO2, PaCO2, and bicarbonate. We only look PaO2 in this case, partial pressure of oxygen, PaO2. After giving oxygen, if the PaO2 is rising more than 150 millimeter mercury, then it is lung condition. When we give enough oxygen, the hypoxia will reverse in lung disease. But in heart disease, there is a mixing of the blood occurring. So even if we give oxygen, then the hypoxia doesn't reverses that easily. That is the concept. Let's move on. Now examine for clubbing, edema, and sweating. Now look at this picture. These are the clubbing. Along with clubbing, what else can you see here? What else?
Cyanosis.
Cyanosis, sir. The fluid acceleration.
Lateral cyanosis.
Cyanosis, sir.
Very good. Cyanosis. Excellent. Look at the blue nails there. Blue nails. Okay, very easy picking. Blue nails with clubbing. So undoubtedly, this hands look like a baby's hand. Okay, a child's hand, I should say. So most probable diagnosis here is cyanotic congenital heart disease. Cyanotic congenital heart disease. Already, this clubbing is grade 3, drumstick appearance. Edema is routinely examined because this is a case of heart disease. Okay, we examine edema on the lower limbs near the ankle area, and sometimes the puffiness of the face can also happen. Sweating is a common feature of heart failure because of sympathetic overstimulation. After that, let's examine the system, a systemic exam. So cardiovascular system is the one which we are examining all the time. So see there, it is done in different headings like inspection, palpation, percussion, and auscultation. Having said that, percussion is not routinely done in a case of cardiovascular system exam. So you can only say inspection, palpation, and auscultation. So what we do in inspection, we just look at the precordium. Precordium is the area which is lying in front of the heart. Okay, cordium is the heart, precordium is the area in front of the heart. So we examine there. Look for any bulging, look for any pulsation. Where is the apex? And is there any scar marks or not? Okay, so bulging may be caused by right ventricular hypertrophy, which is a common feature in tetralogy of Fallot and pulmonary stenosis. Pulsation, if the heart is big in size already, there are different abnormal pulsations seen. Apex also can be seen sometimes, okay, in its normal position or abnormal position. So where is the normal position for apex in a child?
Medial to mid clavicular line at 5th intercostal space.
Yes, sir.
Okay.
Fourth intercostal space.
Fourth intercostal space.
Fifth intercostal space, sir.
Fourth, sir.
Now see there. Now in adults and children, there is a slight difference, okay? But your answer is acceptable. In adults, if your teacher say in adults, then you can say fifth intercostal space, okay? A bit inside the mid-clavicular line on the left side. On the left side, in the fifth intercostal space, inside the mid-clavicular line. I completely agree with your answer. But in children, you come slightly one space above, that is fourth intercostal space, is still inside the mid-clavicular line on the left side. In bigger, like for example, in adolescent, it almost like an adult, because pediatric age group is a very diverse one, isn't it? Adolescent, almost like adult, and there are very small babies as well. Let's move on. Now, what about the palpation? Here, peripheral pulses are palpated. Peripheral pulses, and there are so many important types of peripheral pulses. From the head and neck, we palpate carotid. From upper limb, we palpate brachial and the radial. Even ulnar can be palpated. And from the lower limb, femoral, popliteal, dorsalis pedis, and posterior tibial. I'm sure every student know that already. Carotid, brachial, radial, femoral, popliteal, dorsalis pedis, and posterior tibial. These are the peripheral pulses. We routinely feel them. Now, palpate the precordium. Palpate for thrill. Okay, thrills are palpable murmur. Okay, I'm sure every one of you know. Thrills are palpable murmur. Now, there are certain grading of the murmur which we have recently studied. So to have thrill, what is the intensity of the murmur? To have thrill.
Sir, above the third grade,
Above fourth grade, okay? Fourth, yes.
Sorry.
Up to third grade, the murmurs are very prominently heard. But after they cross the fourth grade, then thrills are associated with them. Thrills are palpable murmur. So just feel for them. Now heave. Heave means it is such a strong type of impulse, usually apex, that it lifts your finger. It lifts your finger from there. This is known as heaving apex or heaving impulse. Now, this heaving term is mainly used for pressure overload conditions, like, see this, heaving or sustained type of apex is seen in aortic stenosis, hypertension, and I want to add one more thing here, that is coarctation of the aorta. Okay, COA. It also results in sustained or heaving type of apex. If I put my finger there, my fingers are elevated by this strong apex, and it will remain there for a moment, and then only it will going down. This is known as heaving or sustained apex. So what is the point here? They are seen in pressure overload condition. So let me write it here for you. Pressure overload condition. Okay. Now, on the other hand, if the apex is hyperdynamic, it is seen in volume overload condition like mitral regurgitation, aortic regurgitation, PDA, VSD, ASD. Okay, these all are example of volume overload condition. This is hyperdynamic apex. Now, what is this? If I put my finger again there, my fingers are elevated, but it quickly disappear. It doesn't stay there for a moment. That is the only difference between hyperdynamic apex and heaving apex. And tapping apex is seen in mitral stenosis. Okay, this is called tapping apex. It is known only by experience, difficult to explain how it feels. Another important point in the palpation is feel for the point of maximum intensity or PMI. Now, sometimes what happens, there are multiple impulse felt throughout the precordium, but which is the strongest one? That strongest one is called apex. Apex has to be the strongest impulse on the precordium. So PMI is also known as apex. Now regarding the auscultation, auscultate or listen for the heart, okay, rate. In a very small babies, we don't palpate the arteries to count the heart rate. We directly put our stethoscope on the chest and count it directly. Okay, so heart rate counting is also done by auscultation. Listen for the heart sounds. What about the first heart sound, second heart sound, any extra heart sound like third and fourth or not? Listen for the systolic and diastolic sound like opening step or ejection click. Okay, and listen for the murmur. So these all are done in auscultation. Now let's talk a little bit practically here. These are the location of various murmur in case of heart disease. Now see this, okay, these are the 4 areas which every student know it already. This is the pulmonary area, here is the mitral area or the apex, this is tricuspid area also known as lower left sternal border, and this is the aortic area. Now this aortic area and this pulmonary area are present on second intercostal space, second intercostal space on the left or the right. Now see this, pulmonary area is present on the left of the sternum and aortic area is present to the right of the sternum on the second intercostal space. Never forget it. Now mitral area is called apex. In case of children, fourth intercostal space a little bit inside the midclavicular line. In adult, fifth intercostal space. This is the left lower sternal border, LLSB, also known as tricuspid area. So these are the different cardiac condition leading to murmur in these areas, like pulmonary stenosis and PDA murmur are heard in pulmonary area. Mitral regurgitation, mitral valve prolapse, and mitral stenosis murmur are heard in mitral area, of course. Aortic stenosis murmur is heard in aortic area, and this LLSB or lower left sternal border or tricuspid area, these are the murmur heard, like VSD murmur, tricuspid regurgitation murmur, tetralogy of Fallot murmur, and tricuspid stenosis murmur, because this TOF also has VSD. So this VSD is heard here. Now, after doing this, different type of examination, the last part is investigation. Now, investigation in a case of heart disease is very simple. Okay, the same type of tests are done. The first one is chest X-ray. Second, ECG. Third is echocardiography. Fourth is a Doppler flow. Okay, the Doppler ultrasound or something like that. You can always add. You can do cardiac catheterization and those type of things. Okay, but in pediatric age group, we don't do all those things. Whatever is necessary, we do. But chest X-ray, ECG, and echo are the must. Now, what is the importance of doing chest X-ray in this type of condition? Chest X-ray will tell us what is the amount of pulmonary blood flow. Is it excessive or decrease or normal? Remember, in left to right shunt, there is excessive blood flow to the lung. This is known as pulmonary plethora. Pulmonary plethora. Okay, excessive blood flow to the lungs. Another one is look for the lung parenchyma. Look for the lung parenchyma means, is there any pneumonic paths present or not? Because repeated lung infections are quite common in case of left to right shunt disease again. Or you can also see, is there any pulmonary edema present or not, like bat wing appearance, we say, ground glass appearance because of a leakage of fluid into the alveoli. Volume overload condition usually cause chamber dilation, like left ventricular dilation or enlargement of the heart. We can see that by chest X-ray Shape of the heart can be seen. Very important point. Like boot-shaped heart is seen in tetralogy of Fallot. Egg on string appearance is seen in TGA. Okay, so important example. And look for the position of liver and skeletal abnormality. Now, there is a condition known as situs inversus and dextrocardia. Situs inversus is associated with dextrocardia, or all the intra-abdominal organs, or visceral organ, I should say, are present on the opposite side. And if liver is present on the left side, okay, then this is known as situs inversus. Situs inversus is associated with dextrocardia, but sometimes only dextrocardia is present without situs inversus, and that is even more complicated situation than the whole situs inversus, because only dextrocardia is associated with lethal type of intracardiac defect. Skeletal abnormality can be of different types, like sometimes sternum is depressed inside, sometimes sternum is bulged outside, sometimes the vertebra, okay, is deviated towards one side, like scoliosis, kyphosis, and these are the different types. So we need to make sure if there are any present, and that can be detected by chest X-ray, PA view and lateral view. Now, another important investigation is ECG. ECG can tell us whether this is hypertrophic heart or not, especially caused by pressure overload. So there is concentric type of hypertrophy, and that can show large voltage ECG wave. I mean, they become quite tall, especially the QRS complexes. You must have studied it in medicine. A similar type of explanation can be given here. Now look at this chest X-ray. All of you please focus here. This is the ventricular septal defect, okay, patient, and this chest X-ray is taken from that patient. Now what can you see here? There is a slight amount of cardiomegaly. Now look at this right border of the heart. This is the left border of the heart. Okay, if I measure it, then the cardiothoracic ratio or CT ratio is definitely more than 50%. That means this is cardiomegaly. Another one, there is a diffuse infiltration like thing we can see on the chest X-ray. See this infiltration. Okay, this infiltration can be explained by two different ways. One, because of the increased blood flow towards the lung, this is called plethoric lung. We can explain like that. And another one, this is a high chance of recurrent lung infection. So this may be a component of lung infection as well. Now look at here. This is called tetralogy of Fallot, or TOF. Now tetralogy of Fallot has got four components. The first is pulmonary stenosis. Second is right ventricular hypertrophy. Third, overriding of the aorta. And fourth, VSD. Okay. Now the typical X-ray which is seen in tetralogy of Fallot is called boot-shaped heart. It looks like boot shape. Now look at this. This exactly looks like a boot. Okay, and this is a leg. So leg and a boot. A boot-shaped heart. Now, what is the reason why this is seen? This is important to understand. In case of tetralogy of Fallot, the right ventricle is hypertrophied. So this right ventricle hypertrophy is elevating left ventricle, okay, upward. So that's how it looks like this. At the same time, the pulmonary artery is underdeveloped in case of tetralogy of Fallot. So the elevation which is shown here by the pulmonary artery is absent. So there is a depression like structure present here. Okay, so all together this looks like a boot-shaped heart. Let's move on. Now, another is TGA, transposition of great arteries. This is known as egg on a string appearance, exactly like an egg from the lateral side. When we see an egg, looks like this, egg on a string appearance. This occurs because of the alignment of pulmonary artery and aorta, okay, in the mediastinum. So these are the very important question, from the MCQ point of view. Just remember, egg on a string appearance is seen in TGA. Now, TOF, these are the 4 components. Okay, so many times I have explained about this: pulmonary stenosis, overriding of the aorta, BSD, and RBH. And look at this. Okay, these are the PDA. These PDA are present in most of the complicated type of heart defect, just to mixing the circulation. Tricuspid atresia. In tricuspid atresia, the tricuspid valve is not developed, so there is a decreased pulmonary blood flow, and there is left ventricular hypertrophy because of the abnormal connection again. Tricuspid atresia, the right ventricle is very, very underdeveloped, or not functioning at all. TGA, you can clearly see the 2 different types of circulation here. See this? This is left ventricle, this is right ventricle. Okay, from right ventricle, the aorta is originating. You can see this. This is aorta. See here, there are different branches of the aorta. And from the left ventricle, the pulmonary artery is originated. It is divided into 2 branches, and this is the PDA, or Ductus Arteriosus at this time, I should say. Okay, Ductus Arteriosus. But after the birth of the baby, I can call it PDA. So in TGA, the baby is comfortably tachypneic. Okay, comfortably tachypneic, usually a big child with saturation in the 50s on room air or oxygen. And this baby is comfortably tachypneic because of this connection called PDA. Otherwise, life is impossible in case of TGA. Now, one small question: why, even after oxygen, the oxygen saturation is only 50% here? Why is that? Anyone?
Sir, because the main blood going to this systemic circulation is the deoxygenated blood. So that's why the saturation is very less as compared to normal condition.
Yes, sir, due to transposition of aorta
Transposition of aorta take deoxygenated blood toward the systemic circulation. That's the reason.
Exactly. All of you are right. Just see here. Now, when we give oxygen, the oxygen will go to the lung. But see what type of blood is going to the lung. Okay, what type of blood is going to the lung? See this? Okay, so there is no difference at all for this deoxygenated blood. It is still there, and it is not getting corrected by the oxygen at all. Only thing, a bit of change occurring is because of this PDA. That's why in this cyanotic type of heart disease, or right to left shunt, even after giving a lot of oxygen, the oxygen saturation doesn't get improved, or the partial pressure of the oxygen doesn't get elevated than 100. This is already proven by Hyperoxia test. Now the last part is the treatment. Now how we are going to treat this type of babies. Okay, let's talk a bit of general type of discussion. We always look airway, breathing, and circulation, especially if those babies are unconscious or if they are very, very sick. Okay, in a comfortable type of child, you don't need to check A, B, and C. In the neonatal period, try to maintain the PDA. Try to maintain it. Don't allow PDA to close, especially in case of complicated type of cyanotic heart diseases, because the baby may be surviving because of that PDA. Now, a good example I can provide you is TGA itself, transposition of the great arteries. PDA is usually present there. If I block that PDA, the child may collapse. So, to maintain the PDA, we need to give prostaglandin E2. Okay, to maintain it, not to close it, remember. So to close the PDA, which drug we give?
Indomethacin.
Yes,
Prostaglandin.
Exactly. Indomethacin or prostaglandin inhibitor, you can say, like indomethacin. Okay, but we don't want to do that. So we want to maintain it by giving prostaglandin E2. And some other supportive type of therapy would be, if there is a congestive cardiac failure, go for the treatment of it. Give diuretics, give vasodilators, give propranolol, especially given in case of pulmonary stenotic condition like tetralogy of Fallot. Take care of nutrition. The child is usually malnourished, especially in cyanotic heart disease. Okay, and go for surgery. Okay. This is the definitive treatment.